Assalamu alaikum, everybody. This is Dr. Fahim, and we have Huda with us, and we're going to host Professor Madiha Hashmi and Dr. Asma Salam with our session 6, which is dialogue on COVID-19. And the topic for today is expert opinion on anesthesiology and intensive care. I'm going to hand over to Huda for introduction to our guest.
Yeah. So, Professor Madiha Hashmi is one of our esteemed guests who is here on a request for her opinion regarding critical care. She's the head of the Department of Critical Care Medicine at Ziauddin University. She's ex-president of Pakistan Society of Critical Care Medicine. She is the leading person in Pakistan Registry of Intensive Care, and she's the founding CEO of Southeast Asia Research and Critical Care Health. Dr. Asma Abdus Salam is an assistant professor of anesthesiology at Ziauddin University. She is also a pain physician at Ziauddin. She is also an executive member of Pakistan Society of Anesthesiologists. So we will be asking them questions about their expertise about anesthesia and intensive care during this time in COVID-19.
So we're going to start off with our questions first.
Dr. Madiha, I would like to ask you first, what measures are being taken to minimize the risk of in-hospital transmission of COVID in your patients?
Okay, Assalamu alaikum, and thank you both of you for your introduction and for this opportunity. And I thank Asma as well because obviously I'm not a Ziauddin alumni, so she asked me to, and it's my pleasure to be here. So, what precautions do we have to take, especially? So, COVID, unfortunately, it's a virus, but it is somehow very contagious. So, the healthcare workers are exposed to it, and obviously, the spread is very rapid. So we are usually very careful, especially in intensive care in theater. Obviously, we take a lot of precautions and try to minimize spread of infection from one patient to the other patient. But suddenly, with this infection, the focus is changed. Now it is the focus is on us now, our like healthcare professional. We have to protect ourselves. Like this is something new, and I'm not used to it because we are always so much focused on the patient's infection कि एक से दूसरे को ना लगे, so be very careful that you don't transmit infection. But now suddenly it's like we are exposed, so the whole focus is that how do we protect ourselves. So here comes then the PPE, which is personal protective equipment. So when this infection started, obviously we were not that used to protecting ourselves. We somehow doctors, they feel that we can't catch infection. So it really took even like people who are working in ICU, in operation theaters, it took us a good, I think, month or so to really realize that how rapidly this virus spreads and how much risk we are at. So gradually we started off with the masks, then the masks changed from surgical mask to N95 mask. N95 mask was something that actually I had never used myself working in ICU because it's TB. Okay, so pulmonologists who are directly involved, they might use N95. Very rarely we would, if we need to intubate the patient or put lines in. So it was not something very common. So it is all very new. Even for experienced people, this personal protective equipment is something which we are not used to, and it's very new to us. So the first problem was availability. So obviously the first few weeks were spent in trying to procure the equipment. Once we have the equipment, it is a biggest challenge to get the doctors to get serious about it, because even now you'll find residents there is so much information out there. Every minute you open the TV, the same thing is being repeated. But even then, even now, you find doctors, residents who don't think it is that important, and you have to catch them that, excuse me, where is your N95? Excuse me, what are you doing? You are not wearing this, you are not wearing that. So it is somehow not sinking into the doctors. So availability was the issue in the beginning. So obviously, especially in government hospitals in smaller setup, it was a big issue. But I think that is resolved now to some extent, and PPE is available, especially locally made PPE is now freely, readily available. Some kind of mask, even if it is not N95, masks are also available. But to get the doctors to wear the PPE is another challenge. And then the other thing is our working hours and our climate. That is a big hindrance as well, because in places like China and US and UK, you are never hot. So it's not an issue that you are wearing a full personal protective equipment. But here, our duty hours are so long. Our other facilities, restroom facilities, that kind of facilities are not there. Garmi hoti ja rahi hai, and then you are asking doctors to, they have to wear. So these are the real challenges which are beyond the availability of PPEs. But I would just request all the doctors, all the anesthesiologists, all the residents who come in contact, because right now you can't even say that, be careful around COVID patients, because right now every patient is a COVID patient until proven otherwise. So emergency department doctors, theater, ORs, ICU, even in the wards, OPDs, so all the doctors just have to take every patient as a COVID patient until the test is there and it says that it's negative. So you have to take the minimum precautions, which is a surgical mask, and protect your clothes. So don't wear your home clothes, and don't take these clothes back home. So a scrub suit and a simple apron, this is the minimum requirement. And then as your contact increases, as you are carrying out procedures that generate aerosol, so obviously then the level of protection goes on increasing, and the maximum you have is then a full mask, not even N95 mask, but I don't know the name. Asma would know the name of that mask, which is like motorized, or I don't know what it is.
It is purified air, PAPR.
Yeah.
It is
So
a
those kind of
respirator.
masks.
Yeah.
And I think Asma did her first COVID positive intubation today. So, it takes good 15-20 minutes before a call, So in an emergency, another very important thing is doing CPR in COVID patients. So doctors, we are like wired in a way that you're very emotional, and when you hear that there is a cardiac arrest or CPR, just mind just stops and you rush and you do whatever. But this is the time when you have to really be very, very mindful, even rushing to rush calls. If you are not prepared, you are not going to do CPR. I know it is just unthinkable for a doctor to not do resuscitation if somebody collapses, but we have to learn to do this and not expose ourselves. And all the guidelines, the UK and American Heart guidelines, they clearly tell you that if you don't have your full PPE, your N95 mask, you cannot do chest compressions, you cannot intubate the patient. So I'm sure it is very difficult for a doctor to understand this and not to resuscitate when a patient collapses. But it is important. And so either you are in your PPE all the time, and if you are not and a call is sent, you have to spend 10 minutes or 15 minutes that it takes to protect yourself and wear the full equipment, and then go for resuscitation. So I hope I answered the question.
Yeah, it was very wonderful information. I'm going to take it forward. And well, since you were one of the pioneer in Pakistan in establishing critical care medicine training, because not only COVID is new to Pakistan, a lot of things even before COVID is new in Pakistan, especially the curriculum that is evolving and having a national registry for intensive care. You led PRICE, which is basically Pakistan Registry of Intensive Care. How important it could have been if it could have been implemented on a national level at this point in time when there's a COVID pandemic. Would you like to comment on that?
Yeah. Yeah, that is something which is very close to my heart. Collecting data and having a database and knowing what we are doing. Actually, we are doing intensive care for many, many years now. It started off in the 70s. So ventilators came, then enthusiastic anesthetists, they started ventilating the patients outside the OR. So that's how the intensive care gradually grew, basically by anesthesiologists in the post-operative care. Then gradually the physicians came in, the chest patients, the TB patients, so the ICU grew. But I feel that we have just been doing it uh, without knowing actually what we are doing, what our patients are. So I'm an anesthesiologist as well, basically. But in 2005, I did a fellowship training in critical care medicine. And since then, coming back to Pakistan, I was involved more and more in ICU and less in anesthesia. And I think it's nearly 10 years I haven't intubated a patient or haven't actually done been inside the OR. So my focus was all on critical care. And I used to attend conferences as well, go abroad, and it was very embarrassing that all we talk about is what's written in the books. So we just make presentations and present because we never have our own data to talk about. So this is how then I realized that I don't want to do that. I want to talk about my patients, what I'm doing, and tell the world that we are not that bad. We are okay, or whatever care we are providing. So the first step was to know our resources. So I needed to do a survey of how many ICUs there are in the country. So a lot of South Asian countries like Sri Lanka, Nepal, if you search them, they have done little surveys and they know how many beds they have. But unfortunately, we did not know that. So I actually had to take a year off, take an unpaid leave for 1 year to map the critical care resources. So I've just put up that paper on the LinkedIn if anybody wants to read it, the landscaping survey of our resources. And the result was that we have zero beds per 100,000 population, zero point 7 intensive care beds per 100,000 population, which is like the lowest of the lowest even in the South Asia. So only Bangladesh has 0.71 beds. Otherwise, Sri Lanka has 2.5 beds. And compare it to 45 beds in US. So that's the other extreme. So our capacity is very little. But at least now we know. So then the next thing was when I knew how many ICUs we have, how many beds we have, what is the infrastructure, what are the resources, what are the human resources. The second thing was to know about our patients. Like what kind of patients do we have? Is it more surgical or is it more medical? Is it chronic illnesses? Are they acute illnesses? What kind of patients? Are they young? Are they old? So our population is very different from the Western population. They are like mean ages in their 70s. And our mean age in ICU is like 30, 40, 50. So our population is very young and very different. So this is how the Pakistan Registry of Intensive Care started. So it started off with 5 ICUs, and now, mashallah, I have 50 ICUs on the registry, and the data is collected daily, and it's live. It's a live cloud-based registry, and I would know that how many beds there are, how many beds are vacant, how many ventilators are available or not. So this was all going good. But unfortunately, most of the government designated COVID hospitals are not on the registry. So that's why in COVID, the mainstream hospitals, since they are not on the registry, and the government also doesn't know how many beds, how many vents, how many beds are available. So it's very confusing. And I really am trying very hard to convince people in the ministry to adopt this registry as a bed surveillance system. But there's a lot of politics, and obviously it hasn't happened yet. So, apart from the 7 hospitals that have been designated COVID hospitals, the other hospitals are on the registry, and we are getting a very good picture of what kind of patients we have. Because WHO, and there's another organization called ISARIC, which is International Severe Acute Respiratory Infections Consortium. So I'm on the board of ISARIC as well. So they have very elaborate CRFs to collect standardized data. So they have a database of nearly 30,000 patients, but that data is standardized. So we are also collecting that standardized data through our registry platform. So we have, if I tell you, 17 so far patients we have that are confirmed COVID patients with a mortality of around 53%. So this is obviously just tip of the iceberg, and it's just a very small sample. So I wish that all the government designated hospitals are on this registry, and then we would have this immense data which will tell us that is this virus the same as it is in UK or USA, because everybody in Pakistan has this feeling that this is not the same, this is something different, because our death toll is not that high. Though it is spreading the same way, but somehow it feels that the patients, the number of deaths are not as high as in West. So how can we answer this or find out why? So why can only be answered if we collect data and then we look at it and then we answer the questions that come up. But it's very difficult in Pakistan to convince people because they're very scared. They're scared of transparency, because once you do something like, genuine data that tells you how many died, how many were alive, what kind of patient they were, so it becomes very transparent. And people are very scared of transparency in Pakistan. So that's why I think they are not, they will maybe never join something like an open registry. And we will never know our patients then. So that's the issue.
So few numbers I was looking on one of the publications, price, that 60% of the admissions that are usually happening in ICUs are unplanned, and majority of them are either surgical patients, and they are either for trauma or neuro patients. So there's a sudden shift of the type of patients, and now all admissions are planned admissions. So for a country like Pakistan with limited resources, do you think statisticians, epidemiologists, and intensive care specialists and anesthesiologists are being taken care of now planning ICUs, or is it still a novel concept to take the real people on board while designing and planning how to run ICUs in Pakistan?
No, I think now everybody is stuck because the numbers are becoming so huge that people are now desperately looking for trained people. But the problem is that where do those trained people come from? It takes College of Physician Surgeons Pakistan. It has a fellowship training program, but it's a second fellowship. So second fellowship means that you need a person who has spent 5 or 6 years training in medicine or anesthesia or surgery or pulmonology or nephrology. So by the time they get their first FCPS, most of them don't want to enter another 2 years training program. So the number of candidates are very small. So every year we take an exam, and maybe I think the maximum candidates that passed 1 year was 6. Otherwise, it's usually 2, 3. So in a 200 million population country, the number of trained people that are come out in the market is like 6 in per year. So you can imagine that the number of trained people are not there. So people, hospital administrators are desperately looking for people who are trained, but unfortunately those people are not available. And I think Ziauddin University has a MS program. Usually MS is not taken very, I think, seriously, or is not considered a very what should I call, a marketable qualification. But I'm very convinced that for country like Pakistan, we need to take doctors after MBBS and then train them in critical care, because most of the ICU, there is one trained intensivist per 82 ICU beds. So if we have like 2,000 ICU beds in the whole country, so every 82 beds will have one trained intensivist. So if this is the rate at which we are producing intensivists, the numbers will never go up. So we are starting, inshallah, from July. We'll have an master's program in critical care, which will be 5 years training program after house job. We can induct doctors, and they'll go through a very structured training program for 5 years, rotating through medicine and through anesthesia, through ER, through pulmonology, and getting like skill based, competency based training. And I'm very hopeful that the numbers will grow up, and gradually, when trained people are there available, they'll be inshallah hired, and then the standards improves with if you have trained people.
But
And I
Dr.
want to
Madiha,
add also one thing, that as Fahim, you said that the number of the surgical cases are increasing in ICU. So one time back, it was thought that the medical ICU and the surgical ICU, they were one entity. But now, for the past many years, the surgical ICU and the medical ICU, they have separated. So medical ICU is mostly looked after by the medicine, internal medicine, or the pulmonology, or the persons who are taking care of the critical care from the medicine side. And most of the surgical ICUs, they are being taken care of by the anesthesiologist, especially in Karachi and rest of Pakistan, and I'm sure in the rest of the world also. So ever since this division of surgical versus medical ICU has come in, now more audits and more registries are being done, and that's why the number of the surgical patients have probably more increased, or you can say that that's why that the concept of the post-surgical patients have come in as well, going to
No,
ICUs.
if you are asking about the registry, why there are more surgical ICUs on it, it's a bias. This
Okay.
registry is biased because as I'm an anesthesiologist, so I know a lot of anesthesiologists. So it is always easy for me to approach anesthetist-led ICUs, which are mostly surgical ICUs, as Asma has said. So
Yeah.
that's why the data will be skewed unless I have equal number of medical and surgical ICUs. My like the survey shows that about 30% ICUs are medical ICUs, around same 34% are surgical ICUs, and the rest are mixed ICUs that take both surgical and medical patients. But a lot of ICUs on the registry are huge cardiac ICUs, so they are all surgical, so the patients are, so the population is more surgical. So I'm very aware of this bias in the registry. That's why it's always the planned elective surgical patients are more.
Yeah.
so
Huda,
Dr.
would you
Madiha,
like?
I was just gonna ask Dr. Madiha about you were telling us about the plan of hiring, getting more people on board in the long run, right? But what about right now? I mean, I know people in UK who were in different specialties, but they were asked to get a 2-week intensive
Crash
course in
course.
critical care to combat the current situation. So, are you planning anything like
Yeah.
that, or?
Yeah, we have already actually planned. There is a course called BASIC, which stands for Basic Assessment and Support in Intensive Care. So this is a course developed by Chinese University of Hong Kong, and it is very much like the FCCS course, which is Fundamentals of Critical Care Support, which is an American course. So as you know, the American courses are always very expensive, and they charge a lot of money. So this Chinese University of Hong Kong, they develop along the same pattern, that course, and they don't charge anything. So we have been doing that course since 2012 in Pakistan. It was a 2-day course, and it goes through the basics of how to assess and recognize a critically ill patient, and then provide the immediate care. And doctors who are not doing intensive care, who are not intensivists. So it is very, very relevant. So in this COVID outbreak, they converted it into a blended learning course, so that all the lectures are now conducted online through an app or through the website. And few online sessions are also held to clarify any things. Even a few skill stations are also held online. So we are only then left with a ventilator skill stations, and airway management skill stations, and rhythm recognition. So these are all skills that are required by intensivists. So these skill stations are then done in one day, face to face. But the first station is always how to don and doff the PPE. So all the students who come, they are in full PPE. So even 5-6 with an instructor, it's a very low risk activity. So this course has been adopted by the Services Academy, by the Ministry of Health, and they have a mandate to train at least 5,000. Just now I was hearing on TV, they were saying 100,000 healthcare workers they plan to train, but definitely about 5,000 doctors we plan to train. And the ministry has provided us with PPEs to give to the students who attend the course. They get the manual free of cost, and they don't have to pay anything. And Asma and myself and a group of other, we have about 45 instructors basic across Pakistan. So we are running these courses. We have already trained about 250 doctors have already been trained in the last even less than 6 weeks. I think 5 weeks that we started off with these courses, because there is a regional director for Islamabad, one in Lahore, and I am the regional coordinator in Sindh. So we have just been running courses every Sunday. I think we are teaching. We haven't taken a day off since this lockdown, because nearly every Sunday, we have been holding these courses. So it's like the whole process takes about 2 weeks. We enroll them, we take them through the lectures, ask them to take the lectures through the app. We also guide them, and then end of 2 weeks, they have the skill stations, and it's pre-course and post-course MCQs as well. So I think it is we are getting very good feedback from the students, especially doctors who are not doing intensive care. They get to know how to do the basic settings of the ventilators, how to manage the airway. So it is a refresher course for people who know intensive care but like haven't been involved. So even senior doctors, they are also doing it because it is kind of a refresher course. So I'm very really thrilled about this course and how the ministry took the initiative. That's one thing they did. They are not adopting the registry, but they have adopted this basic course. And now I think in after Eid, we are doing a course in Nawabshah. Similarly, the Lahore team is doing a course in Quetta. So inshallah, we are going to spread this out across the country.
Okay. Asma, you're obviously an anesthetist. What do you think is the role of an anesthetist in the current situation, and how are you guys reacting to it?
Okay, thank you. Actually, most of the people, they don't understand what exactly is the role of an anesthesiologist is. Anesthesiologist is a perioperative physician. So perioperative physician means that we have to take care of the patients before surgery, which is in the preoperative area. We have to do the assessment, then intraoperatively, and then postoperatively, of course. And then, as Dr. Madiha has already mentioned, that we also take care of the patients in the ICU, which is one of the track for the ICU training as well. and there is pain management. So these are the three essential parts of anesthesiology. You can say that one can adopt one, but these are three of the subspecialties of anesthesia. So when we talk about COVID, as as it was as new to other personnel, it was the same new thing for the anesthesia as well. So initially we were also not too prepared for how to cater such kind of a patients, and how to deal with them preoperatively, intraoperatively, and postoperatively operatively. Then in Pakistan, when the initially the load was not too much of COVID patients, as you all know, but it people started taking it seriously when Italy and America, they had number of cases and mortalities. So before that, we were like, everyone was having a laid back attitude, and they were not taking it seriously. Actually, it started, you would say, after 23rd of March. So initially, when we, as a role, if we talk about the role of an anesthesiologist, when we deal with such kind of a patients, we have to start dealing with them in the preoperative area, which is the preoperative assessment. And the preoperative assessment starts in the ward. So we have made policies afterwards, which caters which kind of surgeries to be done, which kind of surgeries to be held, and later, a national policy was generated in which it was advised not to do the elective cases, only to do the urgent cases, or those cases which are related to trauma, or obstetric patients, or those patients in which the surgery is imminent. So when then we made at our setup, it was all institution, everywhere it was institutional. So every institute, they made their own policies for the such kind, to cater such kind of patients. And in Ziauddin, we made a policy that we will not, if it is an elective case, semi-elective kind of a case which can wait for like 24 hours, so we will do COVID in every patient. And the history in which we had to do the preoperative assessment, we included questions of having recent history of travel initially, but now it's irrelevant, and then fever, and having a close contact of COVID in the family. And for such kind of surgeries which were imminent and which were emergency, then we made a rule that in every patient who is admitted, COVID test will be sent, and we will proceed with the surgery with taking care of it as a COVID positive patient. So everyone would be wearing PPE, and we'll take all precautions. And likewise, we also made policies for the intraoperative and postoperative period, as well as the infection control of the operation theater, infection control and prevention for the staff, as well as we, being anesthesiologists, are also the ones who do the because we are the experienced ones in intubation. So whenever such kind of patient lands in emergency room, we are the ones who have been designated to be given a call for intubation. So then we made protocols according to each situation, and that's
But
how
were
we proceed.
were you guys doing elective surgeries in your hospital, or did you stop for a while because everybody else stopped?
Kind of, we did stop in the few weeks, and we managed in the sense that we decreased our ORs from to half of the elective cases, if they were elective. But most of the cases which were done in the past 1.5 months were all semi-elective kind of procedures, like INDs and trauma cases and obstetric cases, and gynae cancer cases. Some of those, not all, but those which require treatment. So yes, we had been doing, but they were not the pure elective cases. They were semi-urgent kind of procedures, which could have wait for like 24 hours, and then we had to proceed with the surgery.
Professor Madiha, I want to bring you in with some questions related to the role of societies in Pakistan, like Critical Care Medicine Society, Society of Anesthesia. Like everywhere else in the world, every society of medical community was coming up with some guidance and steps while this pandemic was spreading. I don't know. There were a lot of questions from within our community, especially from the young graduates, that we didn't see any rollout of certain guidance or steps from the big societies. If it's true, you want to comment on that?
It's a very, very political question that you have asked, and I'm not going to give you the real answer. But I'm just going to say that the Society of Anesthesiology is, I think, the oldest society, and it's been holding conferences and a lot of activity around that. But I'm more interested in critical care. So, again, critical care, there is a territorial dispute between anesthesia and medicine, and I'm caught in between. So it is not easy because genetically I'm an anesthesiologist, but I have left that and I'm now intensivist. But what about the society? So it's- there isn't there is a society, but there also isn't a society which can be effective in this kind
Sorry,
of
I'm
situation.
going to cut you short. The main concern is that since the virus is different, as you initially we talked about, and it's the talk of the town, that maybe we have a different virus from what UK. All those who are working in hospitals, there's a real concern that we are following the guidelines of either UK or US. So we are caught in between that what do we have to establish for working in
No,
Pakistan?
actually, the government, for a change, has taken a very strong stance, and we have guidelines from the federal government as well as from the provincial government. So let's not talk about the societies because they are really not effective. And this is not the time to try to reorganize the societies. Societies are generally haven't taken any strong stance in any situation. So I think all they do is they hold a conference once a year, and everybody gets together and they get to see something. But that's all what they've been doing. So let's not talk about that, but we can talk about things that are actually happening. So I have those documents, the guidelines. They are quite comprehensive guidelines. We have even had guidelines how to handle the bodies, both WHO and local Pakistan own guidelines. So it was really very, actually, I was very happy to see that within this emergency situation, the guidelines they did come up by the government. So it's not we are not blindly following the UK guidelines. So we have our own guidelines, and obviously they don't talk about things which are not available here. They are only talking about the things which are the medicines and the facilities that are available. So I think if anybody is interested, I can forward you those guidelines. So
Okay.
But
they
are
are.
these like every institution has different takes on their how they're managing their protocols and everything, or is
Yeah,
it
that's
like
always there. Every institution, like Khan would have their own, Ziauddin will have their own. Every institution is making their own guidelines, but there are guidelines that have been given out by the
by
government of Pakistan. So these are like, standard guidelines. Everybody should do that. And I think they're very nice. There isn't any controversy about it. But
And
obviously, then each hospital, depending on their resources, makes their own guidelines,
Certain.
especially the infection prevention and control guidelines. So we made very comprehensive guidelines, our department at
Yeah.
Ziauddin. So they have come up with very comprehensive guidelines with what PPE, which situation to wear, leading up to the handling of the deceased people, bodies, how to handle that. So they are quite comprehensive.
Yes, I would also like to add on that as Dr. Madiha said, because circumstances in every institute is different in Karachi and in Pakistan. So general guidelines they have been made, but every institute had accommodated according to their own circumstances, according to their own logistics. Like as Ziauddin, we are a private institute, so we might have a slight deviation in in the guidelines as compared to Aga Khan, which have their own guidelines and policies and which are being implemented as compared to the government institutes which work on a different scale. So every hospital has got their own policy and guidelines for certain procedures and these this COVID thing.
And these guidelines are also evolving so rapidly, because I remember just 2 weeks ago we had a policy at Ziauddin, that especially the Clifton campus, that we are not going to take COVID positive or highly suspected patients because we are not a government designated hospital. So within a week, those guidelines had to be revised, and the North Nazimabad campus then was declared a COVID designated hospital with isolation rooms as well as ICU. And then just 2 days ago, we had to revise it again, and now all three campuses will take COVID patients, highly suspected as well as positive pressure, as well as the cases that are known. And for that, the infrastructure has been like war footing. It has been going on. So we have negative pressure rooms in the Clifton campus. 4 rooms are there. We are already creating a whole floor with rooms as well as wards which are going to be negative for the COVID patients. Similarly, in the North Nazimabad campus, the ICU will have 6 or 7 negative pressure rooms within the ICU, plus there are 2 floors with rooms and wards that are going to be negative pressure isolation rooms for the COVID patients. And even like tomorrow, I'm going to visit the Kimari campus and make sure that they also have appropriate isolation as well as negative pressure facilities. So these guidelines are really evolving, and on if not daily, like definitely weekly basis, they are changing.
Okay. Dr. Asma, I would like to ask you about intubation in surgical patients. Have you adopted any policies before elective intubation of a patient, or if suspected?
Okay, so basically there are two type of patients if we say COVID in mind. One are those who in whom surgery is elective and we can wait for the COVID test to be done. So those are and they come negative. So we treat them as COVID negative or the regular kind of patients. And then there are patients who comes in emergency or whose COVID is pending, like the result is yet to come. So we consider each and every kind of such patients as COVID positive until the test comes negative. So when such kind of patients they come in, for example, if a COVID negative patient is coming and we have to do the intubation in such kind of patient in the operating room, we treat them as normal patients but wearing the necessary PPE, personal protective equipments, which are the surgical face mask and the gloves and other kind of protections which we do, like surgical gowns and stuff. But for those patients in which we don't know the result of the COVID and there is a higher suspicion of them being COVID positive, so we adopt the same policies and the guidelines as treating them as positive. So we everybody in the OR knows, starting from the recovery room, that the patient who is coming does not have a COVID test, and they would treat that patient as COVID positive. Then we prepare the OR according to the according to the COVID positive patients. Like we limit the personnel inside the OR. We wear the full PPEs with double gloves and N95, and we also limit the number of the anesthesiologists, like resident and the consultant would only be present there, rather than having more people around the patient. And then we try to keep social distancing. We try to in the OR, and we try to limit the trolleys and the other equipments which you say can can increase the spread. So we adopt with them as COVID positive.
But what about number of practitioners that were coming positive in your setup? Have there any been? I heard a few, but have there been any such incidents?
Actually, in Ziauddin, yes, there was an incident, and the incidents is, everywhere. But obviously, we don't know whether the source was OR or not, even though OR operating room or the operation theaters are considered to be a tunnel for, COVID. They are said that they are the tunnels because no one knows where the infection would come. So yes, one of our colleague came positive with, symptoms. And once we came to know that she was positive, then we decontaminated whole of the OR. We kept the OR closed for one day, and we cleaned all the everything inside. And whoever were involved in that case, they were involved along, they were in close contact with that person. So we also conducted the PCR on them. And yes, there were cases that came positive, so we gave isolation to them for 2 weeks, and then the tests were taken, and then they became negative. But most of them were asymptomatic, so we never knew that they were COVID positive or not until on suspicion the test was done, and then they became positive. They came positive, but they were asymptomatic otherwise. So who knows who comes positive? So that's why we have made a policy that every person is considered positive until proven otherwise. And if the COVID is not done, so we don't we try to make as maximum prevention and infection control as possible. We try to follow those guidelines and policies.
So I have a question from some audience regarding because a lot of data that was initially available regarding the COVID-19 was not peer reviewed. So initially it was thought to be ARDS, which is causing these patients' death. And now people are still calling it ARDS, but the management is not what the usual ARDS treatment is. So there's a confusion on how to adjust the PEEP and FiO2 in these patients, and whether and there's another group of school of thought that is trying to delay the intubation of these patients, because once these patients are intubated, the mortality rate is quite high. So I'm going to have a comment from both of you. If Dr. Madiha, you can start with.
Yeah, actually, it's like a pendulum. So early intubation, late intubation, NIV, no NIV. So we started off. So really nobody knows. And I think with our resources, when a patient is there, so you just have to not get carried away with whatever evidence is coming in, because that evidence is conflicting and nobody really knows what will work and what will not work. So we just have to, I think, what I would do is just to be safe and not do anything drastically. And the simple safe thing is, obviously don't rush into intubations, but that also doesn't mean that you delay it to such an extent that the patient is then cannot be salvaged at all. So you cannot really strictly follow anything. You just have to follow each patient as the patient comes, because we have seen patients who have such horrible x-rays and CTs, and they are just sitting there quietly on 2 liters of oxygen and they don't need anything. And so you just have to observe your patient and see where that patient is going. But obviously you need to have the knowledge of everything which is around. There are many few new medicines that are around that we were not aware of or we haven't used it. Then steroids are always hanging in the background: give them, don't give them. So all these controversies will not be resolved, I think, in any time soon. So the best thing is just to be with the patient and see how the patient is behaving, and do things which are safe and will do minimum harm, rather than doing things that you are not even familiar with, because there are many techniques which we are not used to. So instead of trying those modes of ventilation that you are not aware of just because a paper came up, should not be done. So you do what you are good at, you do it safely, and not do things which are new to you and you are not aware of, like full anticoagulation, because I read it in a paper that it's, it's good to anticoagulate the patient, so I will just anticoagulate. So it will have like so many other complications. So I would suggest to do things that you are good at. Like proning is a thing which is simple, cost effective, not dangerous to the patient. You can't do any harm by proning the patient. So giving oxygen through a nasal cannula or high flow nasal cannula is not going to harm the patient. If you have like safety around you, a negative pressure room, you can do NIV. So there's a big controversy whether to do NIV or not to do NIV. So again, stay in the middle ground and do things that are safe for the patient.
Because I haven't seen
Dr.
any
Smile.
ARDS patient, and anesthetize any ARDS patient in this COVID pandemic. So, I really cannot comment more on that, because we have been trying not to take such patients initially, and we have just started taking them. So yes, I did intubated one patient today who was on BiPAP and whose saturation was not getting maintained. He was a hypoxemic, but I could not comment on those patients who come for the surgery, because they have got a very high mortality, and such patients we haven't encountered as yet. But yes, I have intubated one patient today.
We have a question. Does emergency surgery in otherwise asymptomatic person where COVID-19 status is not obviously known carries a high risk of catching COVID-19 and respiratory complications?
It's actually it's not known as such whether they carry a higher risk or not, because it's not even been documented. There are no more, not as much data available on that. But when we consider every asymptomatic patient or every patient with no the COVID status not known, we consider them as COVID positive. So, but we haven't seen such kind of patients as yet in whom we can say that yes, an asymptomatic patient would get converted into a COVID positive or would have a respiratory problems more. It again depends on the individual status of the patient, individual comorbidities, and we have as the data suggests, and so many cases have been coming up that those patients who have more comorbidities, they are more prone to get the serious infection as compared to those ones who are younger and don't have any comorbids. So we cannot say that asymptomatic patients, they have when they go for surgery, they have more chances of going into or having a respiratory complication. But yes, those patients who are COVID positive, yes, they are at increased risk of getting into complications after surgery, and getting complicated respiratory complications after general anesthesia specifically. The COVID positive patients, but we don't know about the asymptomatic patients.
How is a COVID patient different from a normal patient that you plan to do a surgery on?
You see, it depends
How do you
upon the it depends upon the symptom of the patient, COVID patient who is coming to for the surgery. For example, if a patient is COVID positive, and is coming for the surgery, it means that the surgery is imminent, and it cannot be. You cannot delay the surgery or postpone the surgery until the patient gets negative. So when such kind of patient they presents. They must have be having some kind of manifestation, and the manifestation can range from the CNS to cardiovascular to respiratory involvement to renal involvement to the other GIT involvement. So it depends upon what kind of a patients are coming for surgery. So yes, we do expect that in COVID patients who are positive, they would be different from the normal patient, because they would be posing more risk to the OR environment, to the anesthesia personnel, and as well as they might be different in the sense that they might be having the organ involvement in them. and whatever the organ is involved, then we have to cater them accordingly. So that's how it makes them different from a normal adult, that we have to take care of them more as compared to a normal patient, which we also do in the normal patients. But because they imposes risk and they have organ involvement, then obviously we have to take care of the other organs as well.
Yeah, Dr. Madiha, I'm going to have a connected questions to it. And since you talked about the pendulum, there's a pendulum of whether to open the elective surgery or not. Especially so there are two school of thoughts. The one is the private sector, which is taking the brunt because obviously the revenue generating departments are being closed down because no electives. And the other side, sad side, is the severity of the disease is getting worse in a lot of patients who were due to have some surgeries and now they are not happening. So you're gonna have some comment on what we look forward to.
Yeah, again, it's like the lockdown, that half the world, wherever the lockdown is being lifted, people are in favor and people are against, and there is no argument. Both are right, because lifting the lockdown obviously is bad because it's going to increase the people meeting each other, mixing up, no regard for social distancing. So the virus is going to spread. But then, for how long can you continue the lockdown? So there is going to come a point where you have to let the people work because of the economic and financial burden that is being caused. So similarly, it's about elective surgeries. Like, if you ask me that would I go in for an elective surgery, maybe the answer is that no, I will not. I'll be worried, I'll be afraid that I'm going into a hospital for a procedure that can be delayed for a couple of weeks or months. So I would like to avoid that. But then there are other things like infections like cholecystitis, appendicitis, things like that can be delayed. But then again, if you have other comorbids, and they might, then you become too sick, so that can't be delayed. So again, I can't give you one answer to this. It has to be dealt with case to case, patient to patient, that what kind of procedures should go ahead. Something purely elective, cosmetic, obviously should not be done because you are taking an unnecessary risk. But other things, if delaying that is going to cause more problems, obviously then it is, if you take precautions, you can assure the patient that everybody will take precautions, and your risk will not be that high. So then you try to assure them that get the procedure done and don't be worried, because things will be looked after. So you can't generalize again here. It has to be dealt case to case.
And again, there is this thing that now we have to live with this virus. We don't know when it will end. So
So there
eventually,
can't be
this
a limit. In the
lockdown,
beginning,
yeah.
we were very strict for like 4 weeks or so. No elective, absolutely no elective surgery. But again, then how long, we don't know.
Another important
How do you?
yeah, Oda, you would like to ask
Yeah, I was just going to ask about disinfection. How do you decide how long after one procedure in a patient that you suspected was a COVID positive patient? How long do you take to take the next patient in, and what do you do for disinfection?
Yeah. So if we suspect a case as a COVID positive, then obviously we have to decontaminate and sterilize whatever is present inside. So it not only depends on our own protection, which as a staff or or our colleague doctors matters. It's also about the cleaning and the sterilization of the operating room and the equipment present inside. Like, there are two types of equipment which you can say are present in the OR. One is the one which are disposable ones. For example, you can say the breathing circuits or the HME filters or the endotracheal tubes, or such kind of things which you can throw away straightforward. So those which can be discarded and which are disposable, we try to use as maximum as possible, which can be used as disposable ones. But then definitely there are the other equipments which are non-disposable. For example, anesthesia machine, the trolleys, the laryngoscope, the operating room table. So you cannot dispose them off. Then you have to clean them. And for that cleaning between one patient to another patient, now again, if a patient we are suspecting is a COVID positive, that means that that patient cannot have an adequate recovery in the recovery room, which we keep in for like an hour or two. So we have to keep such patients in the OR. And if we keep them in the operating room, so that means that you have to wait for their recovery till they are fully awake or adequate, have an adequate airway to be maintained, so that they can be shifted directly to the ward, so that the other personnel in the recovery room and they do not get infected with such patients. So that time plus the time to clean the operating room, which you can say would take approximately 1 hour plus 1 hour of the OR cleaning take. So approximately you can say 2 hours minimum would be required for one patient to be shifted from the recovery room till the next patient can come in. Minimum of 2 hours, 1 hour of the recovery, and then 1 hour of cleaning and disinfecting and all the things.
And do you have any designated place for keeping these COVID positive patients in the OR?
Right now we are working on that. We had positive pressure ORs, but we are working on to get them negative pressure. But as we don't have one right now, so we have designated one OR which we consider as COVID positive, and in which anyone who is suspected COVID comes in. So we do such cases in only that OR. And we try to keep the air conditioning off during that time, try to limit the staff, so that most minimum people they get exposed to such kind of patients. So we are working on getting them negative pressure, but we don't have one right now.
Dr. Madiha, I'm going to have some information regarding a lot of studies trials and studies are taking place in the rest of the world regarding the COVID-19 and the critical care medicine. We're hearing a lot of medical clinical trials taking place in Lahore regarding hydrochloroquine and other drugs. How many studies are taking place related to critical care medicine? Are there any specific studies happening right now?
Yeah, clinical trials are being registered in Lahore, but I'm not too sure. I would like to see their ethical approvals and the whole process, which I have a feeling that they have not followed the processes which are recommended to hold a clinical trial. So I'm very pessimistic about clinical trials in this country. So I would rather have an observational data then do a trial which is substandard. So for me, it was very important to have this observational study of COVID patients. So we applied to National Bioethics Committee (NBC), and based on the registry, we got ethical approval to do an observational study on the COVID patients based on the CRF and the clinical characterization protocol recommended by WHO and ISARIC. So it is an international study which is partially funded by Wellcome Trust, because it involves making an app application as well. So there are sites that are part of the registry. They will do this study through the registry, but there are sites that don't want to share their data with the registry. So an app has been developed based on the same standardized CRFs that they can use to collect their data, standardized data, but they don't have to share it with the rest of the registry collaborators. So this observational study currently is going on in 15 ICUs, and gradually more ICUs are joining. And it is approved by NBC, and it is like, I'm very sure that it will meet all the standards. So about the clinical trials, then I am collaborating with a few people. There is an international trial, Remap Cap, which is a trial based for community acquired pneumonia, which can be bacterial or viral, and it is a platform trial which is multi-arm. So it will take time. It's not going to happen anytime soon, but we are we have already started working on it, and it is not time limited. It can go on for a while. So I would rather do a clinical trial properly than to rush into something which I'm not too sure about.
And last question to you from here in the session is, do you, since you're more into educational and training side, do you see a drastic evolution or change in curriculum of how critical care medicine training is currently in place, whether internationally or at national level, due to COVID?
Yes, because the interest is there. You would never have heard about intensive care on the national television. You've never heard anesthesia being discussed on the national television. So I think that there has been it's been in the spotlight since the epidemic. It's all anybody can talk about is ventilators, beds, number of vents, number of beds. Like nobody was interested in that. And I did my survey, I don't know why, 2 years ago. So nobody was interested. People actually made fun of me that why are you wasting time? Get somebody to call them up and find out how many beds they have. And it was like considered a waste of time that I did. But now, since that my survey is actually all the government decisions are based on that survey, because how many beds, where are those beds, how many ventilators, because my nobody would know that in a DHQ hospital is there an ICU or not, what kind of an ICU, what kind of people are there. But because the survey was very detailed and it tells you about not only the infrastructure but about the human resource as well. So that survey has become the basis of everybody's queries of how many beds and how many ventilators. So with that much interest generated, I'm sure younger people who are still thinking, deciding what career to take, maybe they will get attracted to it. And we have already, like, we are prepared. Our master's program, inshallah, is going to be launched in July. The CPSP program is already there. And I would also like to take this opportunity of your platform to let the younger doctors, younger generation coming up, that search is the platform, Southeast Asian Research in Critical Care Health. So the platform is there. People who are interested in doing research, even formal research like as a master's program or a PhD program. So this is the platform that I have made only for the doctors from Pakistan to bring out research and publications, and especially Ziauddin, because now this platform is with, because I am based in Ziauddin now. So everybody is welcome to come talk to me, discuss their projects based on this registry data, because this registry is running for 2 years now, and we have about 30,000 critical care patients data on the registry. But that data obviously is helping policy making, is one thing in which the data helps. Then research is another thing. So it provides an opportunity for younger doctors to come up, ask questions, and then try to answer those questions based on the data. So this platform is open to anybody who wants to get involved either in a project or as a master's or a PhD program, because I'm collaborating with Critical Care Asia, which is funded by Wellcome Trust. So this is basically for capacity building in low middle income countries. So people who are interested, they will be supported, they'll be funded, their researches will be funded, and above all, we'll get answers to questions that are relevant to us and not from US or America. So I would really like to invite all of you who are listening or who will listen to Come forward if you are interested in research and utilize this price and search platform to bring out research and publication from the country.
That's wonderful news. I think that's icing on the cake for this session from
Yeah.
Dr. Madhya.
Yeah.
Huda, you wanna take end note from Asma and Dr. Asma?
Yeah, Dr. Asma, would you like to close give us a closing comment about the challenges that you faced in these times, and then how did you prevent that or overcome it?
Okay, first, but before answering your question, I would also like to answer Dr. Faisal's
Yeah,
question. He's my senior and more like a big brother to me. So, if on a personal note, if you are asking Dr. Faisal, Assalamu alaikum, if you're asking me on a personal note, then obviously I cannot say no to you. But yes, on a professional basis, if you give me a valid reason that why this laparoscopic surgery is necessary, and if it is necessary and you cannot postpone it, then definitely I would allow you to perform that. Otherwise I might not. So it depends upon what reason you give me for that procedure to be done. But yes, on one-to-one basis, yes, definitely I'll allow you to do that. And Huda, as you were asking me about the challenges, so on a closing note, as anesthesiologists, we are I wouldn't say that we are the only frontliners who face such patients, because ER personnel and the medicine person, they see them daily in the clinic, and so but yes, we do face different kind of challenge. Our challenges are different from theirs, being that whenever such patient, first is from the support from the or rest of the OR team, that we have to make them, as Dr. Madiha said initially, that we have to make people wear face mask, we have to make people wear protective gears before such patients come in. So now most of them are tuned in. We had to give them teachings on how to wear, how to don, how to doff, and how to receive such kind of patients whenever a patient is coming in the operating theater. Then obviously tuning the surgeons on which elective surgeries not to be done, and then the COVID test to be done in every elective patient, and having, if a patient is coming with a suspicion, get the chest x-ray done even in an asymptomatic patient, but otherwise young patient, but having suspect with a suspicion of fever or other symptoms. And if such patients who are coming negative, but their chest x-rays are coming positive, then we also do further testing like CT scan of the chest, so that the infiltrates and opacities can be ruled out, and even uh, uh, treating them as COVID positive. Now, having said that, the other challenge which came to us was the cleaning and the infection control and making of the policies which were relevant in our setup, and then making them negative pressure ORs. So we are still in the process of that. But the biggest challenge which we face on daily basis is to keep our staff, to make our even own residents, to make them comply with the policies, and the to wear the protective gowns, and we have to make sure in every patient that everyone, we have to pinpoint everyone that, oh, please and wear N95, please wear gloves, please do this. So this is one of the biggest challenge which we have been facing since this COVID has come. And then definitely the other challenges are, I still feel that we are lagging behind in teaching them, or having workshops, or having a drill on how to conduct such kind of, how to proceed with such kind of procedures. Because as I said that we also cater the emergency intubations, because the most experienced person who is intubation should do intubation in COVID positive patient.
yeah,
So it's not only about the operating room, it's also about the medical ICU or the other wards, where the staff are not adequately trained on how to assist us in intubation, in the process of intubation. Because the OR personnel, they are quite adequately, they assist us very smoothly. But
yeah,
medical ICU, or the ward staff, they have minimum idea of how to assist an anesthesiologist whenever such kind of a patient comes in. So again, we need more drills and more workshops and more training sessions on them, with them, so that they can be prepared for such kind of patients.
Dr. Madiha, you want to say the end remarks before we say bye to our viewers, and any resource or any websites you want to advise to people who would like to learn about some guidelines or critical care medicine. The such information is wonderful for especially young graduates of Ziauddin to follow. So last
Thank
remark
you
from.
very much, I think, for Dr. Fahim and Dr. Huda for conducting this interview very nicely. And you've already done a bit of research as well, so you knew what price is, what kind of data is there. So I'm really very happy about that. And the websites and research, obviously, ISRIC is IS, International Severe Acute Respiratory Infections Consortium. So if you go on the website, you will see the clinical characterization protocol, and you'll see the CRFs which are recommended by WHO and ISRIC. So you can have a look at them and see if you are dealing with COVID patients in Pakistan in an ICU or even in a ward, and you want to collect some data. So you can download those CRFs from there in the paper form, and you can collect data, because a case series in this epidemic will be invaluable to tell us about the patients that we have. And then obviously there you might find, who knows, that we find that it's behaving totally differently to whatever we are hearing from the West. So I would request you, obviously the manpower is short, everybody is overburdened, overworked, and nobody wants to think about data at all. But my request is that if you can hire somebody, or if you can delegate it to somebody, a junior person, a nursing staff, a technician, anybody. So don't waste this opportunity. If you are working with COVID patients, either in the ward or outpatient or in intensive care units, do spare some time and jot down the minimum information which is required. There are many tiers of data that you can collect. The simplest rapid CRF is only 1 page. It goes up to tier 0, which is like nearly comes out to be 13 pages. But if you are very short of resources, you can collect the minimum information, but it will be invaluable. So that's all I would like to say. Clinical management, obviously, everybody is doing their best to manage this patient with whatever resources they have. But the thing that is being ignored is collecting data. So I would request you to not ignore that and give it some time, because it will be invaluable. Because this is something new, and we don't know what's going to come at the end of it all. So thank you very much for this opportunity, and thank you, Asma, as well, for
Yeah,
inviting
my
me.
pleasure. But I'm really thankful to Fahim and Huda, especially because they have initiated this such a much needed, as well as ZMC alumni collaborating with the rest of the batches was, it was truly a pleasure. That's the only pleasure I would say ever since the COVID has come, in the sense that it has created such a positivity in the group and among the ZMC alumni that we are all
Very
together.
nice.
So,
Yeah,
yeah,
thank you.
thank
And
you
Thank
I'm
so
always
much.
there if anybody wants any help, any guidance, they want to get involved with any project, research. So I'm always there.
Yeah, I
Thank
wanted
you
to
so much.
tell our viewers also that there's a presentation on Ziauddin page from Dr. Asma. There was a webinar conducted on role of
Yeah.
anesthesia. Viewers can go there and also check that presentation. And thank you for giving an extended time, Dr. Madiha,
Yes.
for this session.